Dr. Deemer is going to take over. Dr. Deemer has some data on this technique and superior oblique weakening procedures that he'll share with you as well.
So thank you very much, David. I was hiking on an island off the Southern California coast when I rounded a corner and encountered this animal and became concerned that I myself might undergo superior oblique weakening if I didn't back off. Now, this work was funded by the National Eye Institute. I do not have any commercial interests or financial conflicts of interest to disclose. Now, we should bear in mind that overdepression and adduction is not always due to the superior oblique muscle. In fact, things like heterotopic pulleys can produce this pattern here, this kind of A pattern with overdepression and adduction, as you see, and this will occur if the orbits are encyclorotated so that the lateral rectus is superior relative to the medial rectus pulley. This results in the medial rectus pulley not only medial rectus muscle not only adducting but infraducting. So if that is the case, the fault does not necessarily lie with the superior oblique muscle or its tendon. But let's assume for now that you've decided clinically that you want to weaken the superior oblique tendon. What is the biomechanical basis for that weakening, and how can we understand the Z tenotomy operation? Well, look at the unroofed human orbit as seen here. We have the superior oblique muscle belly at the bottom. It's reflected in the trochlea that we have dissected free, and the tendon then expands to its anterior and posterior insertions on the sclera. If you excise this whole unit en bloc, you can identify the trochlea, and having cut the trochlea away, you can unroll the superior oblique tendon from the inside of the trochlea, and lo and behold, it looks very much like a rectus muscle with a long tendon. It's composed of parallel muscle fibers and parallel tendon fibers that run pretty much uninterrupted from one end to the other. So you can divide some of those tendon fibers and not others, but there isn't much coupling from one adjacent fiber to the next one parallel to it. Now, we try in the laboratory to understand the biomechanics of Z tenotomy, and here you see a diagram of a tensile testing device that clamps the tendon specimen between clamps, and then we can extend the distance between the two while measuring the force that is applied to do so. When the tendon ruptures, that's called the failure force, and I'll be describing data that quantifies the failure force. A Z tenotomy, as David showed you, involves cuts on the margins of the tendon from opposite sides. Illustrated on bottom right, for example, would be a 20% Z tenotomy, leaving the central 60% of the fibers intact and continuous from one end to the other. Suppose we do this in a specimen of latex rubber, which admittedly is artificial and not like a tendon. So we can see here if we load it, if we pull as seen on the bottom with an 80% Z tenotomy, we see a reduction in failure force. In fact, failure force declines linearly with the amount of Z tenotomy. Okay? Once you get to 80%, you've got about 1/7 or so the maximum failure force that you started with. However, in an actual superior oblique muscle, you get a very different response. Now, this is a bovine superior oblique tendon here, and we can see the example here in the upper left of before and after the loading of a 20% Z tenotomy, but 50% we get really a little strand after loading, and the same is true after 80%. Key here is that the failure force becomes negligible after 50% or more Z tenotomy because you don't have any fibers running continuously from one end to the other. You get the same kind of behavior for the superior rectus tendon. It's made out of the very same material. You can see here that the failure force becomes negligible, that is nearly zero, after 50% Z tenotomy because you've interrupted all continuous fibers in the tendon running from one end to the other. So, for less than 50% superior oblique Z tenotomy, the tendon failure force declines non-linearly, unlike an artificial material like rubber. For more, superior oblique force transmission is reduced to nearly zero, which is equivalent to complete unguarded tenotomy. In conclusion, if you think you need at least 50% superior oblique Z tenotomy, you might as well just cut the entire tendon. You're not creating a graded response past the point of 50% Z tenotomy. And if you're in doubt, you can lose a suture bridge between the two ends, just in case you need to go back later and reunite the tendon. I myself prefer to use proline suture, blue proline suture, because it's easier to find if that becomes necessary. Thank you very much.